Good evening, all our guests tonight. And tonight we will start our first session of the October series webinar. And today we're going to have all our guests tonight. And tonight today we will have a talk on public health this time, and also some communication skills. And for today's session, I will invite Dr. Faizah Bohari. She is the head of population oral health and clinical prevention from the Department of from Faculty of Dentistry UITM to introduce our speaker tonight. So without further ado, I will invite Dr. Faizah to take on the session now to introduce the speaker. Dr. Faizah, the session is yours. Faizah, you can introduce the speaker.
Thank you, Professor Dato. Assalamualaikum and good evening to everyone here with us on this Zoom platform. I would like to bid a warm welcome everyone here for making time to attend this webinar tonight. Before we proceed further, please allow me to introduce myself. My name is Dr. Nur Faizah Bohari. I am a dental public health lecturer in Faculty of Dentistry, University Technology Mara, Malaysia. And today is my privilege to moderate tonight's talk titled Motivational Interviewing in Dentistry, Making Every Contact Count. Before that, some housekeeping announcements before I introduce the speaker. Should you have any questions you would like to ask the speaker or to discuss or to address, kindly type in your questions or requests in the chat box, and I will read out and relay the questions on your behalf. I am very pleased to introduce our speaker tonight, Associate Professor Dr. Budi Aslidi Mat Sabri, who is my colleague and my good friend. Dr. Budi graduated from the University of Malaya in 2004 and worked as a dental officer in Selangor for 3 years before joining University Technology Mara and pursuing her Masters in Dental Public Health at the Queen Mary University of London and her Diploma in Dental Public Health from the Royal College of Surgeons, England in 2007. She then proceeded to pursue her PhD in Dental Public Health at the Queen Mary University of London in 2009, after which she rejoined UITM to serve as a full-time lecturer. Dr. Budi is currently the Program Director of our UITM's Master of Science in Dental Public Health and Doctor in Dental Public Health programs. She has undergone the SCOPE Tobacco Cessation Training, completed the Tobacco Treatment Specialist Program at the University of Massachusetts, Boston in 2016, and the WHO Fellowship for Tobacco Control, Hong Kong in 2018. In 2018, she also received the American National Certificate in Tobacco Treatment Practice and is registered with the NAADAC, which is the American Association for Addiction Professionals, and ATTUD, the Association for the Treatment of Tobacco Use and Dependence. She is actively involved in tobacco cessation counseling and promotion through the faculty's accredited Quit Smoking Clinic, which is MQuit Clinic, and through community oral health promotion programs. Her research interests include social behavioral sciences, health education, health determinants, and also health promotion. Without further ado, I would like to invite Dr. Budi to deliver her talk. Dr. Budi, the platform is yours.
Thank you, Dr. Faizah. Give me a moment to share my screen.
Yeah.
Okay. Hi, Dr. Faizah, can you confirm that you can see my entire slide?
Yes, Dr. Budi, it's perfect.
Perfect. Okay, hi, Assalamualaikum and good evening, everyone. Thank you very much for the kind introduction, Dr. Faizah. And thank you for this opportunity to speak virtually to all of you on a topic that I'm quite passionate about, which is motivational interviewing in dentistry, making every contact count. Um, the concept of motivational interviewing has been has been around since the early 1980s. And it is actually an approach that is used to help people who may be struggling to make decisions in every aspects or in certain aspects of their lives. And the use of MI is a patient-centered approach where recognizing that the patient needs to feel responsible for their own behavior and that they need to feel responsible for their own behavior change is central to this theory of motivational interviewing. So, despite being health professionals, this particular concept where the patient is responsible for changing their behavior might not be something that we as dentists have given much thought to, because I think a part of being a dentist is that we take on that expert role where we help our patients change, and we are very, very actively involved in making changes to our patients' oral health. So tonight, I hope to take you to a new concept, which, well, not necessarily new, but I think it's actually quite thought-provoking, where we transfer the burden or the responsibility of the oral health to the patient themselves, because motivational interviewing is about helping, facilitating the change and helping patients to work through their ambivalence. So traditionally, behavior change interventions have always focused on us as clinicians exerting our influence on our patients to change their lifestyle without considering factors such as the patient's motivation for change, their ability to change, or even their ambivalence towards change. We always have the assumption, we may have the assumption that when patients come to us, that they want to improve their oral health and that they are ready to do the changes that is required to actually improve their oral health, when this situation may not always be true. On a micro level, behavioral change in a clinical setting is obviously influenced by a doctor-patient interaction. And the patient is usually attempting to exert their autonomy by resisting change, which is being asked by the clinician. So, for example, if you take a situation when you see a patient in a clinic and you're telling the patient that, look, you have to cut down on your sugar intake. And in a great situation, the patient is happy to cut down on their sugar intake, but more often than not, sometimes patient will try to defend that they're eating just the appropriate amount, or that that's not the reason for whatever problem that they're facing. So they try to exert their autonomy by resisting the change that we would like to get them to do. And this obviously will result in failure to achieve whatever behavioral outcome that we are trying to instill in the patient. So, for example, I think as Dr. Faiza had had actually introduced me earlier, that I have quite a lot of background in terms of smoking cessation. And to be honest, motivation interviewing is something which is really important for smoking cessation. And I guess that's where I started being introduced to the concept of motivational interviewing. But I think after using it for quite some time and being exposed to it, and even doing some research on motivational interviewing, I see that it actually is something to be considered for dentistry, even though the usage in dentistry has not been exactly as popular as for other situations. So in smoking cessation, studies have shown that there's an increased trend in terms of quit rates with MI as compared to conventional brief advice. And quit rates were found to increase by an impressive 26% as compared to conventional advice. And of course, even though the main success of MI has been seen in the addiction field, for smoking cessation, for alcoholism, but MI has also been used extensively for behavioral change in other areas, such as for pain management, for diabetes management, or dietary management in terms of mental health issues, for medication, pharmacotherapy, and actually even oral health. So when we talk about dentistry specifically, when we see something is wrong or when we see something that needs our attention, we naturally want to correct it. When you see a cavity in someone's mouth, what you want to do is you want to line it and fill it up, isn't it? But in MI, this need to actually repair something is known as what we call the writing reflex. And unfortunately, the writing reflex may cause pushback from the patient, and this can actually hinder change. And altering the way we deliver information to the patient may mean the difference between the patient's behavior in terms of the change in terms of outcome, whether or not the patient will change or the patient will remain the same. So instead of simply telling a patient to brush their teeth twice a day and expecting the patient to actually follow your advice, motivational interviewing is actually a method which allows the patient to discuss and allows them to decide whether or not the course of action, whether brushing twice a day is something that they want to do, and whether they're willing to do, and whether they are capable of doing or not. So I'm just going to use simple examples like changing the sugar diet, brushing, because I think those are simple examples. But for those who have had patients who resist even following instructions like having to floss or having to brush your teeth twice a day, you'll understand that even these simple instructions are difficult to implement for your patients to actually carry out. And this is where simple or brief motivation interviewing can come in handy. Of course, when we talk about motivational interviewing as a whole concept, it is quite complicated. It can be elaborate. When we want to get a patient to, for example, quit smoking, it may take a few sessions before it takes into effect. But that doesn't mean that motivational interviewing can't be used in our daily contact. It can be used as a brief intervention in dentistry. And it should be used as a brief intervention because our core business is treating the patient. But even despite the fact that treating the patient clinically is our core business, the sustainability of what we do depends on behavioral change. Okay? So dental teams are actually ideally positioned to provide the preventive advice and brief interventions, and it may not be the changes that may occur due to MI may not be limited to oral health changes, but as we know that oral health risk factors share common risk factors, so they may also impact other chronic diseases, which is why we have to take this opportunity to actually implement MI in dentistry. Some studies have shown that MI in dentistry outperforms conventional education for health outcomes. For example, MI was found to be more effective than conventional health education strategy in eliciting positive changes in adolescents' oral health behaviors and preventing dental caries. However, at this point, I think when we look at systematic reviews, conclusive evidence is still lacking, not because individual studies do not actually yield success, but rather because of the heterogeneity of available oral health studies looking at MI, which means that more and better designed interventions are needed to fully access and to fully assess the impact of MI in terms of oral health. But that's not a reason not to do it. That's a reason to explore it further. Okay, so motivational interviewing as a concept is actually underpinned by a series of principles that emphasizes a collaborative therapeutic relationship in which the autonomy of the patient is respected and that the patient's intrinsic resources for change are elicited by the therapist. In this instance, motivation to change is actually determined by the client, and it is not imposed by the counselor or by the clinician. and the client or the patient actually owns the responsibility to resolve his ambivalence. When we talk about ambivalence, which I will actually explain a bit more later, it's about the indecisiveness on doing one thing or another. When they are unsure whether they would like to actually quit smoking or do they want to remain as a smoker, do they want to actually do flossing, or is that taking too much time out of their lives? Should they not floss? Should they actually floss? I mean, in life, as in anything, we always have ambivalence. Do we want to do something? We might know all the reasons for doing something. It doesn't mean we actually do it. There are different pulls that pulls us in different directions. Motivational interviewing is about owning up to is about helping the patient or the client to realize that they need to find a way out of that ambivalence. It also allows the clients to pursue their own means of change, and understanding that allowing them to pursue their own means of change will actually increase the likelihood of success, because you're allowing them to decide on how they would like to change, in what method do they want to change. The client-counselor relationship is a collaborative or friendly partnership rather than an expert-recipient partnership. So it's about us being there as a partner rather than as an expert opinion or as a mentor where we tell the patient what to do. So the dynamics of the relationship between the doctor and patient slightly changes in motivational interviewing. In the conventional doctor-patient relationship, there is an understanding that the doctor is the expert and the recipient is the patient. And I mean, that was a traditional relationship. And in certain transactional relationships, the doctor actually takes on a parental role, and then the patient takes on a childlike role. So the patient actually is only receiving information and the doctor is giving information. But for MI, that relationship would not work. You need to have a partnership where it is a supportive relationship rather than a purely guiding relationship. Okay. So client resistance and denial are viewed as a reaction to counselor behavior and not as a client trait. So it means that when you have a patient and the patient is resisting to change, it's not because the patient is resistant, but because you as a clinician have not been able yet to actually counsel your patient to actually make the change. So the responsibility in terms of facilitating the patient is actually on you. It is your skill as a motivational interviewer that can actually move the action plan for the patient. Okay. And of course, the spirit of motivational interviewing also says that prescribing a specific method or technique would be ineffective because it has to be client-centered. So there's no specific technique, but there are guiding principles that you can actually employ which will help, but you will have to look at it on a case-to-case basis and what works for your client. Okay? And I think that's one of the challenges in terms of motivational interviewing. So even though I said that there is no specific method, but as a concept, there's what we call a spirit of MI. There's a concept that we can actually follow, which is a guiding clinical style. And the acronym is actually PACE, which is Partnership, Acceptance, Compassion, and Evocation. This style actually allows the patient to reflect on their own motivation to change. And this actually goes beyond how we communicate with them verbally. It's not just about how we talk to the patient, but it also includes our attitude in approaching the patient, our body language, and our facial expression. So sometimes, I mean, in the talks that I've given before in terms of MI, the questions that I usually get are, but how do we change our attitude? I mean, we can change how we communicate, but how we look at things, can we really change how we view a situation? And the answer to that is that we can and we should. I think one of the core issues about MI is to actually have an approach where we're not judgmental towards our patient, and we cannot be victim blaming. We have to look at the patient as someone who we empathize with and who we understand, and we have to accept the patient for who they are. We should not at all have a judgmental attitude where we say that, yeah, I mean, serves them right, or, you know, what do they expect? They can't expect to have perfect teeth if they're not willing to, you know, do what they're supposed to do, or they can't expect that they can quit smoking if they're not doing the steps towards achieving the change. You can't have that attitude. Your attitude, if you're hoping MI is going to work for your patient and for you to be good at delivering MI, is that you will have to have an attitude of non-judgmental. Okay. So the first spirit of MI, the 4 aspects here, which I mentioned: partnership, acceptance, compassion, and evocation. The first one, partnership, is about working together with equal input from the patient and from the clinician. So it is a sharing of power and expertise. You would share your expertise, you would share their power, the patient shares their experience with you, they share their knowledge with you, what they know, what they don't know. They share the issues they might face, their fears, the things that are barriers to them. So it is a partnership, and it requires equal input from both sides. And of course, in order for you to get the equal input, it is important that the respecting patient autonomy is there. You need to respect the autonomy of your patient, otherwise then there's no partnership. Okay, I think that's very important, that is a concept that we need to embody in order for MI to work. And then in terms of acceptance is about understanding the patient's perspective, not being judgmental. I mentioned that a few times before. Ensuring that we focus on their positive health behaviors. I mean, focus on the positive. Everyone has something positive, you know. I think someone said in every situation, no matter how bad or how bleak it is, there's always a silver lining, which is similar when it comes to our patients. No matter how bad the situation may look like, no matter how bad the behavior that they have, there will always be a silver lining. So it's about how you would like to extract that silver lining, being supportive of that silver lining, and supporting them with their self-efficacy to change the unhealthy behavior. So that's something very important. When it comes to acceptance, I think I've actually, in a talk I've done previously, I once mentioned, imagine having a patient come to you in clinic and say that, "Doctor, I'm sorry, the patient comes with their child, maybe a 5-year-old or 6-year-old child, and you notice that the child has got rampant caries and very bad oral hygiene. And when you ask the mom, how come that, the child's oral hygiene is such, and the mother answers, "I'm really sorry, doctor, I'm working 2 jobs, I'm the sole breadwinner for my family, and I really do not have the time to monitor my child's toothbrushing." And you try to cajole the mom into, maybe monitoring at least just at night, or helping the child to brush their teeth in the morning at least. And the mom says that they can't, and they don't know how to get out of it. They are very concerned, but they know that they can't put in the time. They do not have the resources to actually help. And you're trying to empathize with them, and you're trying to find that silver lining on whatever is positive. And I asked the participants at the talk that I gave, what could they tell the mom to make the mom feel that they are at least doing something right? And I wish I could ask you to answer, but I don't think that that's possible today. Or maybe Dr. Faiza would like to answer that question. What could you possibly tell the mom to actually, try to empower the mom, to tell them that they are doing something right, to show the mom that you empathize and that you accept them, but you're trying to also acknowledge their strength? What could you tell? What could you say to the mom? Dr. Faiza, would you like to respond?
Okay, that's quite challenging
Situation.
because we as dentists, we always used to, just jump into the problem and tell the patients that, the oral hygiene of your child is very bad. We always say the negative, words. Okay. So might be we will need to use, maybe is it like reverse psychology, Dr. Budi? Let's say okay, I know you have been trying really hard to take care of your child's oral hygiene, but then we highlight the problems of the child. Is it okay?
Yeah, I would accept that answer, but I was thinking for this particular mom, I mean, because she's saying all the negativity, right? She can't do this, she can't do that. And if I'm really trying to, is like grasping for that silver lining, what I would say is, ma'am, the fact that you're here today talking to me about your child shows how much you care about your child. And we can definitely work from that. From that, we can definitely work on something because you obviously care about your child. And because of that amount of care, we can definitely work about, on how to move on from here. So what do you think, Dr. Faiza? I mean, that's really being positive, isn't it? The fact that the patient is there and you, because for me, in that situation, that's all I can think of, that the patient is there. That is a first step. She's there with her child. That shows that she cares. And I think as a mother, when you listen to that, you're feeling really bad about yourself. You think that you can't do anything for your child anymore, and you've sort of given up, knowing that this clinician is saying she acknowledges your effort to bring your child there and is not being judgmental about the fact that you're not brushing your child's teeth. She's not being judgmental about the fact that your child has rampant caries. I mean, that I think will actually motivate and spur the mom to think that, you know what, I can do this. Because, I mean, I myself, I don't have a child, but every time I take my cat to the vet, I get really scared because I think that my vet is going to say, I'm not taking care of my cat well enough. And it has actually driven me once to actually tell the vet that my cat's a stray because I was scared I was going to get scolded, So you imagine and put yourself in the patient's shoes. I mean, that's how you feel when you feel that you're going to be judged. The same way I felt that my vet was going to judge me about my cat. So, but having a clinician who is not judgmental, but is actually practicing MI, showing affirmations like that, will change your whole outlook. And from what you feel you can't do, you now feel empowered that, maybe you have it under control. Maybe you have what it takes to actually do something, okay? So the next thing is about compassion, having concern for the client's situation. Compassion is about supporting your patients who may be struggling with behavior change and showing empathy. And of course, evocation, which is an attempt to explore what is important to the patient and how they would like to make it change. So all these four things have to be combined in order for MI to work. You need to have that partnership, that rapport of your patient. You need to show acceptance in terms of autonomy, empathy, showing lack of judgment, giving affirmations. You need to have compassion. And you need to actually have evocation, where you need to invite the client's views. You need to be interested and curious to know what the client wants, what the client feels, what are the barriers that they perceive. Because without wanting to know all that, how can you proceed? You don't know the client, okay? So, I mean, it sounds like a lot of work, doesn't it? And it sounds like, how am I going to do that in between, trying to do scaling and then putting on GIC for whatever cavity that needs GIC. I mean, it sounds like a lot of work, but you have to remember MI is also a state of being, meaning that if you have the right attitude, and after a while, this will come naturally to you, and you'll be able, when you talk to a patient, you don't actually think about it anymore, about how you're going to do acceptance, how are you going to show empathy, but it comes naturally, and it just comes like that, it comes together. But of course, MI takes practice. It's a skill and it needs to be practiced. Okay, so like what I mentioned, how can we practice MI in dentistry? It's not something that is simple to do, but it can be done. So one of the things is, I think in my story, the analogy I gave before, the ability to express empathy is important. In practical terms, an empathic style of communication actually involves the use of reflective listening skills and accurate empathy. Because when I say accurate empathy, you need to be able to actually express it in a form which is sincere. Because patients can tell when you're not being sincere, and if you're not sincere, what you think sounds like empathy is going to come out as sarcasm. So that's something which is very important. You have to actually seek to understand the patient's perspective and their feelings, and you need to try to express that understanding. And you need, and I have to stress, and it has to be sincere, because otherwise, even though you're saying the right words, it's just going to sound sarcastic to the patient, and that is the opposite of what we want to achieve when it comes to MI. Okay. What we want is actually for you to create an open and respectful exchange with your patient, and in order to do that, you will actually need to approach your patient with genuine curiosity about their experience. It's okay to ask, like, okay, why, for example, if you ask a patient, what drives you to actually drink Coke 5 times a day? You can ask that. You can even be curious about asking it, but doesn't mean that you're judgmental about it. But you want to know why. It's okay to ask, because knowing why and understanding why can help you actually come up with solutions, or help guide the patients to coming up to solutions to changing that behavior. Okay. At the end of today's talk, I've actually included 2 videos that will actually explain this a bit more, the things that I'm talking about. Okay, so moving on, and then another skill in actually conducting MI is actually developing discrepancy. So why is developing discrepancy important? Because it's important for us to make the patient or the client see the difference between what they're doing now and what they want to achieve. If they do not see, for example, if someone wants to be fit, or someone wants to lose weight, if their goal is that by New Year they would like to have a normal BMI, but their current activity is always having a midnight snack, then you need to show them how the expected outcome and the current behavior does not match. Because even though you feel, you would think that it's obvious, if that's what you want to achieve and this is what you are currently doing, that's not going to happen. But the truth is, patients or people, I mean, not just patients, but even ourselves, we need certain things to be put in clear perspectives for us to be able to see. Most often, people are motivated to change when they hear it from themselves. That's one thing, rather than from someone else. So they need to hear in their own words whether or not what they're doing now will actually ultimately result in their desired outcome. For example, someone who wants to be able to run the marathon in 2022, and they say that, okay, my aim is I want to run the marathon. And then you ask them, okay, so now, are you actually routinely running during the weekends or even every day? And they say, no, I'm not. I'm just watching Netflix all day long. And then you say that, okay, so you're watching Netflix all day long and you're never exercising, but you're hoping to finish the KL marathon in 2022. And then you make them say that to themselves, and then hopefully then they can see the discrepancy. I mean, that's just a very simple example. Because sometimes people have goals, but then they don't reflect what are they doing to achieve those goals. So developing discrepancy is about helping them see whether what they're doing now is actually towards that goal or not. Okay. For example, a dental example, you can ask them, okay, how have you been protecting yourself from getting to decay? And they may answer, I'm brushing myself once a day. And you might say, oh, the recommendation is to brush twice a day. And then you ask them, um, how would you feel if you get caries? And then they might answer, oh, I'm going to be really upset. So then you would reflect to them, you're telling me that you haven't been brushing twice a day, and yet you're also saying that you really don't want to get caries, you're really afraid of caries. So how do you feel about, how does these two things fit? You're not doing what you're supposed to be doing, but at the same time, you really don't want to face the consequences, Hopefully that can put things in perspective as an example. Okay. And one thing is that in terms of motivational interviewing, we would like to avoid argumentation. We don't want to argue for clients because it's a partnership and we are trying to work with the client, not against them. Okay, so in one of the reasons why avoiding argumentation is very crucial is because arguments usually strengthens people's belief. What happens when you are in an argument is that you are busy trying to bring forth your argument. You're trying to justify why you're doing something. If I have someone argue with me about something, then I'm going to try to prove that I'm right. And what happens is I'm close to listening. I mean, I've closed off myself to listening about the other point of view because it's now an argument. So the how do we say, the goal of an argument usually is to win. So in order to win, the response is always about trying to stand up for whatever is it that they believe in. And that's not helpful in trying to change, isn't it? In order to change, you need to help your clients to actually see new perspectives or see new areas where they can actually move towards rather than holding on to whatever that they've been doing. So avoiding argumentation is something important. And how do we actually avoid argument is that when you sense that signs of an argument are present or starting to be present, stop the conversation and indicate that the intent is not to take sides. So you can say that, okay, I'm not here to judge or to say that you're wrong or right, but I just want to understand where you're coming from or why you're doing certain things. That's about not being judgmental. Because we don't want to confront the patient, we don't want to argue with the patient, or we don't want to intimidate. Definitely, we don't want to intimidate the patient because that's just going to lead to resistance. And they're going to be defensive. And so when they're defensive, they're going to resist, and that's going to be the opposite of behavior change. But rather, when we have resistance, we will roll with it. We'll let them play out the resistance. We ask them, okay, so why are they resisting? Why are they resisting? What's causing the resistance? What would they need to not resist? For example, if it's a patient who's smoking and they say that I'm not going to give up the cigarette, instead of saying, but you have to, they say, but I don't want to. I mean, that's not going to end, isn't it? We're going to be here all night. But if you ask them, okay, could you tell me what is it about smoking that you like so much? What would it take for you to actually give it up? Those are the things that you want to ask them, that you're not actually trying to go against their resistance, but you're trying to understand their resistance. And what happens when that is that if the client perceives that you're rolling with them, they will take a step back and they will let you in, and they will actually be more amenable to change, or at least to listening to whatever it is that you need to say to them. Okay? And then in terms of supporting self-efficacy, this is also a very important skill in motivation. Sorry, I think I accidentally muted myself. I hope everyone can hear me now.
Yes, Dr. Budi, now we can hear you.
Was I mute long?
Yes, just a while.
Okay,
Just a few
that's good.
seconds.
Okay. Many people with enduring negative behaviors may have had it for a long time. I mean, a lot of people who have negative behaviors, for example, I mean, when it comes to dentistry, you say negative behaviors and then you start saying not flossing, that makes it sound really bad, doesn't it? Which is why I find it that, you know, using those examples can be a bit uncomfortable, but okay, let's go with not flossing. So let's say the enduring behavior is not flossing. So they've probably not flossed for a long while. They've probably, you know, woke up one morning and decided, okay, I'm going to start flossing every night from now on. And they do it for a week or so, and then they stop flossing because, you know, other things come into play, or they just simply forget. I mean, that's a very simple example, flossing. But the thing is, they've probably tried, they've attempted to change whatever negative behavior. When it comes to alcoholism, of course, people try to quit and relapse many times. Similarly with smoking cessation. So the thing is, what happens when they relapse or when they fail at certain things? It actually makes them, for every time that they fail and fail yet again, it can be more and more stressful because it makes them feel that they're not equipped to make the change, or that they can never make the change. But what we have to focus on is that they have actually succeeded at one point and then they failed, but they succeeded. So you need to support that self-efficacy. You need to help them see that they've attempted it. You need to provide hope and give them self-confidence that they have the ability to change. And sometimes you may not be able to find it within flossing because they've never tried flossing, but you can find it in other aspects of their lives. Let me give you an example of smoking, because that's what I do a lot for motivational interviewing, so I have better examples. For example, when it comes to smoking, you might have a patient who says that, okay, I tried to quit smoking and I was successful for a while, but then I gained weight. And I find that that's very discouraging because I've really worked hard at losing weight and I managed to get to my ideal weight, and now I'm gaining it again because of smoking. I don't think I can handle this. But what you can also hear is that this patient has succeeded at dieting and exercising to lose weight. And that's not easy, isn't it? So you can capitalize on that and you can say that, wow, you've actually succeeded at changing some other lifestyle, which is losing weight. And if you have that capacity to do that, then you definitely have that capacity to stop smoking. You know, you need to tilt the focus. You might not be able to use the same example with whatever it is that they're doing now, but you need to look at other aspects of their lives and see how they can do it. And I've actually put an example on how we do that in the video at the end, I think. And I think it'll be easier when we show the video. Okay, next. This is what we mentioned earlier about ambivalence, where ambivalence represents a patient's experience of simultaneously feeling two ways about changing their behavior. For example, concurrently wanting to make a change while also feeling reticent to do so. So within the clinical exchanges and within MI theory, we talk about ambivalence as the client expression in favor of change as change talk, and the client's expression in favor of staying the same as sustained talk. So change talk is when they say something towards behavior change, whereas sustained talk is when they talk in a method where they don't want to change. They want to stay how they are. Okay. For example, I know I should not smoke, or I know I should not drink alcohol, but I think I want to have fun, or I deserve that cigarette, or I deserve that alcohol. So then the I deserve to have fun, that's the sustained talk. I know I should not drink is part of change talk. You know, the acknowledgement of, I know I shouldn't. That's part of change talk, or towards change talk. So in dealing with ambivalence, a part of the clarification process is to find out what motivates the patient so that you can move them from being in a state of ambivalence towards change, okay? And it helps you to decide on how to push them towards change. So in dealing with empathy, ambivalence, rolling with resistance, that's quite a lot that we've covered, which I know may be quite confusing for those who are new to MI. But the question is, how do we do all that? I mean, how are you going to express your empathy? How do you know how to actually deal with ambivalence? What are the skills needed to actually roll with resistance? So in MI, we have what we call ORs, or open-ended questions, affirmations, reflective listening, and summarization. So these are the four core motivational interviewing skills, which can be used in the basic interaction with patients that we should use early when in our interaction with our patient, okay? So open-ended questions. They are questions that encourage a longer response with many possible answers. Don't ask your patient, do you eat sugar? Yes, no. Do you think you can cut down sugar? Yes, I can. No, I can't. You don't want to answer questions like that. So instead, you want to ask questions that will actually allow you to explore what the person is experiencing and feeling, what are their perspectives. Please bear with me. I know it seems like, okay, we're never going to be able to do this in clinical setting, in the dental setting, because it sounds like it's going to take forever. Well, it does take some time, I admit. I'm not going to lie and say that, oh, you can do this in a minute and get, be successful at MI. It's definitely going to take a bit more than a minute. But it doesn't necessarily have to take longer than 5 minutes. You can do a brief MI in 5 minutes and still get to your goal, to your outcome that you intended. So please don't give up just yet and say that it's definitely not for dentistry, because it is. Okay, so the purpose of actually using open-ended questions is that it actually establishes a safe environment where it builds trust, because in terms of asking questions, how you ask them is very important. For example, you might want to say, I have to think of an example. Okay, if you're asking a parent about their child, you can ask, what do you do to protect yourself or your child from getting cavities? And the parent might answer, well, I brush my child's teeth with fluoridated toothpaste twice a day, or I make sure that they don't eat snacks in between meals. And you can ask, okay, what do you think has actually worked in the past in terms of controlling your child's diet? So they may tell you what has worked, what might not have worked, or how difficult it was. But imagine asking in another way, which is not really in the, it is open-ended, but it's not in the style of MI, where you say, why didn't you brush your child's teeth? That's kind of victim blaming, isn't it? So that's not a question that actually encourages a positive approach, because it kind of blames the recipient. So compare these two. The first one was, what do you do to actually protect your child from getting cavities? Possibly they might answer that, actually I'm not doing that much, but they're not defensive at that answer. They're admitting that they're not doing much. And that's actually a much better situation to be at, rather than asking, why didn't you brush your child's teeth? And they may answer, because I don't have time. And now they're defensive. And they're justifying why they're not doing it. They're not feeling guilty for not doing it. They're justifying why they're not doing it. You don't want them to be in that situation. You want them to feel that, I may not have been doing it. Now they're feeling responsible to want to do it. Okay, so that is about the type of questions and how you should be asking them. Of course, please bear in mind that I have only been given, I think, about 40 minutes, which I am actually close to coming to an end, and I have so many more slides to go. So I really can't go in depth in this, and in order to really do MI, you really need to go in depth. But I'll try to hurry it along a bit. Okay. And then, of course, affirmations are important. It's about telling your patient that you notice the positive aspects in them. Affirmations should be about the client. It's about making the client feel good about themselves. This will actually help in terms of self-efficacy, definitely. But then you have to remember, it's not about showing your judgment on the patient. So it's about affirming what the patient is positive about, but it's not saying that you approve of it, even though it's affirmations. So for example, you should not say, I am impressed that you brush your teeth. You shouldn't say that, but rather you should say, it's good that you brush your teeth. Because saying it's good that you brush your teeth puts the focus on the patient, and it is validating that the patient is doing something correct. But if you're saying, I'm impressed with the fact that you brush your teeth, you're saying that you're judging the patient. So the negative part is that if they don't brush their teeth, if they're doing something negative, then you may also be judging them negatively. So for affirmations, the core issue is validating what the patient is doing, not expressing your judgment. Okay, so that's something about affirmation. And of course, reflective listening is a skill that has to be used. It is to demonstrate that you understand the patient. The purpose is to demonstrate that you're hearing what they're trying to say, you're understanding what they're saying, and it's also an opportunity for you to reflect back to them so that they can listen to what they have said. And then maybe it can actually trigger an understanding that maybe things are not what they should be, or things may not be as bad as they should be, or such forth. Okay, because when you reflect to them what they have said, then they get to hear it, and we know that change based on hearing what the discrepancy in terms of what they want and what they're doing, hearing it in their own words is more powerful than hearing it from your words. Okay. So reflective listening is a key component in MI. Of course, there are many types of reflection. You have the simple reflection where you just simply repeat back what they say, or you can actually amplify what they say, or you can paraphrase it, or you can sort of reflect feelings and make them feel more of what they're saying. And the video at the end will also use some reflective listening, and I hope I will have some time to show that to you. And summarizing is a part of MI, which, because in any conversation, we don't want the conversation, you've discussed a lot, and it gets a bit messy here and there, but ultimately you need to come to a conclusion. So the summarization is actually what can actually help the transition from, the self-awareness, the empowerment that you were trying to do as part of your conversation. So the summarization is what can actually help the patient transition to a realization of what they want to do next, or where we can go from here. Okay, so there are many types of summarization. It can be a collective summary, a linking summary, or a transitional summary. And then we have what we call the guiding principles of MI, which is acronymed as RULE, which is resist the writing reflex, understanding motivation, listening, and empowering the client. Okay, take a look at this photo. And just looking at this photo, what are you thinking of feeling when you look at this? Well, if you're honest, don't you feel that a kind of an urge to turn the turtle over and put him back on his 4 feet? I mean, for those who are not scared of turtles, that is. But, well, that is what we mentioned earlier, the writing reflex, the need to actually correct things. And for MI, it is very important that you really need to fight this reflex. You need to resist it. And this is definitely going to be difficult because as healthcare professionals, as educators, that's is inbuilt in us. We have this corrective lens. We want to change the client behavior. We want to make things right. So we argue, we push back the client. We're arguing for the change, we want them to go, we want them to be healthy, we want them to make the changes. But the problem is when we are arguing with them, we're trying to we want to actually, do the writing reflex, the client is going to push back. So we need to fight this. We need to roll with whatever resistance. We have to acknowledge, we have to understand that it's inbuilt in us. Automatically, in the video later, you'll see that even though I was trying to do a demonstration, part of me, I had that writing reflex. It comes naturally. So that's something that we need to work on, okay? We need to actually focus on the client rather than trying to right what is wrong. We need to focus on looking at it from the client's perspective, okay? It's important to understand motivation. In order for us to actually get people to change, we need to understand what can make them change. People change, people are motivated for different reasons. We have external motivators, we have internal motivators. For example, getting fit, winning a medal in a marathon might be an external motivator. But the satisfaction of completing the marathon, knowing that you've managed to do something you've never done before, would be an internal motivator, right? So that's an example on understanding what motivates a person. Sometimes for certain people, internal motivators are even stronger than external motivators. But for some people, it's the other way around. So you need to identify that within your client so you know which button to push in order to help them change. And understanding the values of your client can also go a long way. And also, of course, as we know, values are very closely tied to culture. It may be tied to their upbringing and their religion. Even though it sounds like you have to get to know them so well that you have to know your client almost intimately, but it's not. If you're skilled enough, you can pick up on these values and by what they say, by how they talk to you, and being able to pick up on these things can help you. It can actually strengthen how you actually conduct the behavioral change exercise that you're trying to achieve. Okay. I mentioned briefly earlier something about change talk. So when patients talk to you, ultimately they will let slip. They may say things like, I want to do it, but it's difficult. So at least you know that there is a desire for change, and then you can work on that desire. They can say that, I know I can do this. I know that I can stop smoking anytime if I wanted to. I just don't want to. I mean, I hear that all the time from my patients. Doctor, if I really wanted to, I could quit cold turkey. Then I'm thinking like, wow, you know that you have the ability. You know that deep down you can. So what's stopping you from doing it? And then they say that, oh, but because I don't want to. And then you know the issue is not confidence, but the issue is maybe the need to, self-awareness of why they should, the reason for doing something. So those are things that you need to listen for when the patient is talking. You need to be able to identify the change talk when your patient is talking to you. Okay, and of course, empowering the client, encouraging participation, acknowledging the patient's strengths, things that I've mentioned earlier. These are all very important. And of course, decision making is shared. We try to invite the patient to come to that decision. We can guide, but the decision when to stop, what to do, what method to use should be the patient's decision, because ultimately they're the ones who will have to do it. You can prescribe to them that you have to do this, this, and this, and the patient might not do it at all. It would have been a wasted, prescription of activities if the patient is not happy to do it. So it's very important that decision making is shared. and best if it comes from the patient, what they want to do. Okay, you can offer guidance, but it should come from the patient. Another concept of MI is discord. I'm just looking at the time. It's already 10:30. Okay, discord is actually disagreement of opinion or position between the client and provider, which is arguments. And discord is something that you might want to avoid, but it's also important to actually recognize discord. So you can recognize discord in your patient when they say, yes, doctor, but I don't want, but, you know, I understand, but those are signs of discord. And when they argue, obviously that's a sign of discord. When they show negativity, or simply when they're very passive, you're the one doing all the talking, they're not jumping in to say how they feel. They might say how they feel, which might not be consistent with what you expect, but at least they are responding. Positivity is something that you want to avoid, and you have to work it out with your patient. Okay, so in avoiding discord, it is something that should be avoided because it becomes a barrier to change. So I've put these two pictures because think about the first picture is I'm assuming is two people trying to wrestle, right? So they're ready to lunge towards each other. So what happens in a wrestling match? So when two people are charging towards each other and hopefully like they look equally strong in this photo, what happens is most likely they're gonna remain at a standstill. You know, they're gonna be locked in a match, and neither are moving until, you know, one knocks the other down, obviously. And you don't want this to happen because then the session is not going anywhere. You're locked in you know, a wrestle. But rather, imagine leading your partner in a dance, swaying together in the same rhythm. You know, if it's a tango, you're going back and forth. So ultimately, towards the end, you've achieved your objective, which is to finish the dance. But similarly to MI, the common goal is to have behavior change, or in this particular dance, to finish the dance. Similarly, in MI, a dance is not straightforward. You move back and forth, you sway, you twirl. So in conducting MI, it is also not straightforward. Sometimes you need to move with your patient. You need to understand where they're coming from. You need to give in. You need to allow the patient to take lead. But there are times when you can also invite the patient's response towards where you want it to go. So it is about moving together and avoiding discord. Okay, so that's the concept of MI. And ultimately, finally, we need to, of course, close the deal. At the end of the session or communication, it's important to transition to a definitive plan. You don't want to have to go through everything that I mentioned before, which is a whole lot, and come to the end of the session not knowing what was the outcome. So you need to close a deal by transitioning to even a minor action plan. Like, okay, so we've decided on this. At least, do you want to focus on something else? Would you be willing to consider doing this? Or would you want to know more about something, a referral or a subsequent plan? It's important to help the patient to recollect what has been discussed and plan on what's next. So that's what should be done with your patients. So since people say that a picture is worth 1,000 words, and I've tried to put a lot of pictures in my presentation, I thought I would amp it up a bit for the closing by showing a video instead. However, due to privacy issues, I can't show you a video of a real case recording, so I apologize for that. However, thanks to the efforts of my postgraduate students who so kindly volunteered to help me in the last minute, we actually did a demonstration, 2 videos to demonstrate MI. The quality of the video is not that good, but I hope it would suffice for you to see. And I hope we will be able to shed some light on some of the things that I've actually discussed earlier. However, I think it's important to note that when I say that these are brief interventions of MI, it doesn't mean that everything that we did in the video actually, it's not the ideal MI video, but rather there are some mistakes in it that was done to show things that, because I wanted to trigger what you feel that we could have done differently in the video that we did. But anyway, without further ado, I'm just gonna play the video for you to watch first. Hello, Diana. It's good to see you again. It's been quite a while. I think it's been a year since your last checkup with me. So how have you been coping with the current pandemic?
Hi, doctor. I guess I'm doing fine, and yeah, it has been a year since our last checkup. I have basically been staying at home, eat and work. Yeah.
Okay. Do you have any concerns regarding your teeth that you'd like to share with me today?
I do have some sensitivity sometimes, especially on my lower teeth. It's not too bad, but I notice it's starting to be a little bit disturbing.
Okay. Why don't we have a look?
Okay.
All right. Okay, Diana. I've noticed a few small cavities actually starting to form in your lower molars. It's not too bad. I'm sure we can do something about it today. But before we do that, I'm actually a bit concerned because I want to get down to why you're developing these cavities now. Could you fill out the risk assessment form and a dietary sheet for me?
Yeah, sure.
Okay. Okay, Diana. Actually, I can see here that you're consuming a bit of sugar, actually quite a lot of sugar, in the form of drinks and desserts.
Yeah, I think it's all because of the lockdown, and I'm quite bored sometimes, so all I do is eat.
Yeah, the lockdown has been hard for everyone, hasn't it? The thing is, I have a feeling that your eating pattern, especially about the sugar consumption, may be responsible for the sudden increase in cavities in your mouth.
Oh dear.
What do you know about the effect of sugar on caries?
Well, I have heard that too much sugar causes caries, but doctor, I do have a sweet tooth. I love my desserts and soft drinks, juices, and cordials. I know sugar is also bad for health generally.
Okay, that's good. But have you ever been concerned about how sugar is affecting your health specifically, or your mouth for that matter?
Well, I know about diabetes and I have concerns, so I try to cut down by only eating 2 sweet snacks or desserts a day and limit to only 2 candies a day.
Okay, I think it's really good that you're doing something to control your sugar intake. But I noticed, based on the form that you just filled out here, that you are eating about you're eating sugar 5 times a day at least. So can you elaborate about that further? Like, when are you eating the sugar?
Well, I'm actually trying to cut down, so what I do is I portion my cake, for example, into smaller slices, so I still got to eat throughout the day instead of just during tea time. And I do the same for my creams. I would sip on my cola slowly to make it last.
I see, okay. Actually, Diana, when it comes to sugar, it's especially when it comes to sugar and caries, it's not only the amount that matters, but also the frequency of you taking the sugar. Have you ever heard of this concept before?
No, doctor. I thought as long as I reduce the amount, it reduces the risk. I don't think I can part with any more of my sweet drinks.
Okay, I understand. There's a reason why it's called comfort food, isn't it?
Yeah.
But would you like to know more about why the frequency matters?
Okay. But I don't want to part with my sugar treats. Is that okay?
Okay, the thing is, every time we eat, a process called demineralization occurs in our mouth, and that's how cavities start to form. It takes around 40 minutes from the time we stop eating before this process actually normalizes. So eating snacks all day long will cause your mouth to always be in the demineralization process, and that leads to cavities.
Oh, I see. But the thing is, because like I told you, I am now working mostly online at home, and I need to snack to keep me alive, to keep me awake with the online meetings.
Okay.
So I need my juices and coffee. Otherwise, I am going to zoom out during the online meeting.
Sure. I'm hearing that you're saying you need to snack, but then you like sugary snacks. But do you think you could consider, say, keeping the sugary snacks or desserts with the main meals, and perhaps snack on low sugar snacks or drink unsweetened beverages in between meals? I mean, that way you still get to have your comfort food, but you get to minimize, the risk that it has on your teeth. Would that sound like something that you can manage?
That sounds actually hard for me. I don't think I like the sound of it. Because I don't think I can manage that, honestly.
Okay, okay then, that's fair enough, but could you tell me which part of the plan is a no-go? I mean, what part of that plan that I just suggested that you think would be the hardest thing for you to do?
I think it's the unsweetened coffee because I think that's a no-go for me. I really need my sweet lattes and macchiatos.
Yeah, I love my coffee too. Okay, but I'm glad you mentioned that. Would you be open to listening to, let's say, hearing about some suggestions on alternative sweeteners that would taste great with your macchiatos and lattes? Would that be something you would want to know about?
Alright, I think that sounds like a plan.
Great. I think we can move on from here and work on something that would be doable for both of us, isn't it?
Yeah.
Great. Okay, all right. So that was the first video, and before I think I'll just go on to the next video before we end this for the Q&A. Okay, so then.
Hello, Jenna.
Sorry.
Okay, Faiz, we have finished our dental checkup for today. Everything looks good, but I did notice that you have quite a bit of staining on your teeth. In fact, I think that the amount of staining seems to be quite a lot more than in previous checkups. I think that the stains might be from your smoking habits. Do you mind if we talk about it?
Sure. Well, actually, I also noticed the stains, and I guess that's why I'm here. I don't like the stains, and yeah, I'm still smoking.
Okay, guys, we will try to sort this out for you. I can definitely do a full scaling and polishing for you. But before we do that, can we talk a bit about your smoking habit?
Sure. I know it's a nasty habit, and I've heard all about the dangers of smoking and all, but I can't seem to give it up on smoking.
It's good that you know about the danger of smoking. But I think that is definitely the first step in the right direction. So, Faiz, you mentioned that you think it's a nasty habit. What makes you say that?
Well, I notice my mouth smell very bad sometimes, and my friend also mentioned about it. Even my family also hate about smoking.
I see. So you are telling me that you are stressed out with the smoking smell and worried that your friends and family might not like you smoking.
Yes.
Would you say that you are concerned about that to actually motivate you to quit this smoking habit?
I think that's hard to say. I've thought about it, but I've been smoking for so long that I can't imagine living without. I mean, I have a puff after every meal, and that's the first thing I think of when I wake up.
I see. When you mentioned that you have thought about it, could you tell what was the biggest factor that inspired you to want to quit, and what was the biggest hindrance?
Well, the biggest factor was that my family and friends don't like me smoking, but the biggest hindrance is that I enjoy smoking very much.
What is it that you enjoy about smoking?
It relaxes me and gives a sense of contentment. And you know, it's like a form of satisfaction, like when you get to eat your favorite food or watch your favorite movies. And also when I do smoke, I kind of feel a bit incomplete.
Okay, so I am hearing that aside from just enjoying the smoking, you are saying that you are quite dependent on it, that without it, you feel incomplete. Do you think that you are addicted to smoking?
Well, now that you put it that way, maybe I am. I mean, I usually think of it as I enjoy it, but without it, I feel incomplete, so I guess I am addicted to smoking.
Okay, do you think you will be able to quit smoking?
I don't know actually. I guess I've never really given a serious thought about it.
Okay. If I ask you now, in what condition do you think you can see yourself quitting? I mean, what do you think will trigger you to quit?
Well, having a medical emergency related to smoking would do that, I guess. Or getting an ultimatum from my family.
So that kind of suggests to me that you do not that this motivation is quite serious actually. If at the end of the road it may fix you to having a medical emergency or an ultimatum from your family. But I guess the question is, are you willing to wait until you get to the point, or do you want to do something about it now?
Well, I guess it would be a good idea to address it now, but I really don't know where to start, or if I even can start something.
Would you like to know more about what I can do to help you through this? I could give you some options, and you can tell me what you are comfortable with.
Sure, I would like that.
All right, so actually those were two videos. Now looking back at it, I have to say I apologize that I know the acting is really unnatural, because I will have to say that my students and I are very camera shy, and that accounts for the very unnatural acting. But I hope it still gets the point across about what motivational interviewing is. And I think maybe we can discuss it in the Q&A, but just a comment between the two different motivational interviewing. I can say that the second video shows better a better motivational interviewing session as opposed to the first one. The first one has an attempt to follow the spirit of MI, but the doctor, myself, was very quick to try to give suggestions and, was a bit controlling and not as relaxed in inviting the response. I was trying to tell the patient, she should stop eating cake all day long, and get her to give up, only eat it at certain hours. I mean, in terms of dentistry, all those advice were correct advice. But as you can see from the reaction of the patient was a bit hesitant to try it until I invited the patient to tell me what is it about the plan that they didn't like. I could have improved that session by actually asking the patient from the beginning, if I had to ask you, for example, what could you do to reduce your sugar? What would you want to do that you think you're willing to do to reduce your sugar? Then we could have avoided all the, back and forth between me giving suggestions to only drink at certain times and the patient saying, no, that's not something that she can do, I mean, ultimately, yes, we got to where we wanted to, but the skill that was demonstrated in the first video was not very ideal. It could definitely be improved on. And I purposely did that video that way. And the second video was much better, showing how the dentist is actually inviting the patient to actually come to the realization that, he might want to consider quitting. Of course, at that point, he has not quit, or he's not even saying he wants to quit. But from never really giving it much thought, now the patient is considering that, he's open to the option of looking at what he can do to quit. So that is actually an achievement on its own within 5 minutes. So I hope those two videos can kind of put in perspective what motivational interviewing is and not really motivational interviewing. Okay, so okay, before I conclude my presentation, I think it's very important to actually admit that there are some barriers in implementing MI in dentistry. And I know it's been an earful listening to me this evening. There are a lot of things within the dental setting which may be a challenge to MI, such as time pressure. The skills required in order to master MI is something which will take time to acquire, and the fact that we feel that we are the experts when it comes to dentistry is also a challenge to resist that. Writing Reflex, all those are challenges. And of course, sometimes you'll have patients who says that, doctor, I just want it to be filled, like they don't even want to hear what we're saying. I just want the hole to be filled up. I just want the scaling. And those things are the barriers. But aside from all those barriers, I think the pros for actually adopting MI approach with patients who are resistant to change are still compelling. because studies have shown that change as a result of MI are more sustainable. The change would actually be very beneficial to the patient. And I think for that reason, it's still something worth thinking about and considering to actually do in your practice. While maybe MI may not be advocated for all patient interactions in all types of practices, but I hope tonight's session will actually allow you to explore your own ambivalence about doing MI and maybe consider whether you're willing to actually do MI within your own practice. Thank you very much. That's all from me.
Thank you, Dr. Budi, for the very insightful talk on motivational interviewing. I'm sure we can try to apply this method in our practice so that we can enhance our communication skills and, further strengthen our rapport with our patients and, giving the autonomy to the patient. At the same time, we are working as like a partnership with them to achieve the same goal. Yeah. Okay, so we have a few questions from the participants. The first question is from Dr. Arfa. I just want to know your opinion on how to deal with patients in rural area. Most of them don't really bother about taking care of their oral health, mainly because maybe of the living cost nowadays. They even share one toothbrush with the whole family members, and this may limit us to encourage them. Although we gave them free toothbrush or toothpaste from the NGOs. Okay, Dr. Budi, you can answer.
Okay. Thank you for the question. Okay. I think there are two things that we need to consider in this situation. Economics is definitely one thing. When if they can't afford to do certain things, if they can't even afford to buy floss, then it's going to be difficult for you to ask them to buy the floss to do flossing, for example. But when it comes to behavior, it's also about priorities. Yes, in certain extreme situations, it'll be difficult to try to put forth the importance of buying a floss or floss set when they can barely eat. But it doesn't mean that you can't actually advocate for change, because if you can actually instill a sense of prioritization, that health is actually something that they need to prioritize, then I think ultimately you can still achieve the outcome that you want. But of course, I can't answer whether in a situation where they can't even have a toothbrush, can you actually use MI to get them to prioritize buying a toothbrush? That's a bit difficult to answer. But if you say, for example, then you have the support of having NGOs come in and buy toothbrush, then MI can be the difference between them taking the toothbrush and just throwing it away and not really utilizing whatever it is that you're providing, and the difference between that and for these parents to take whatever resources that you give, the limited resources, and making the best use of these limited resources. I think that is what MI can do. It cannot actually answer the issue of the limited resources, but it can help the patient to actually make the best of whatever it is that they have, to make the best choices. I think that is what MI can help. I hope that answers the question.
Yes, certainly. Okay, thank you, Dr. Budi. Next question from Dr. NAMR. In developing discrepancy, sometimes it is difficult for a dentist not to sound sarcastic or even condescending. So how do we consciously practice MI, particularly in a clinical situation when the time is always limited? I know you have answered about the time constraint, but can you further explain about how not to be sounding so sarcastic, especially sometimes in our mother language we tend to speak that way, and maybe we don't intend to, but maybe that's the sound of some sarcastic when we do this MI.
I agree. Okay, actually, to answer this, I think in order not to sound sarcastic or condescending, is really to have the attitude that you are not judgmental. That's the first and foremost. Because no matter how much you hide it, if in your mind you're feeling judgmental, I think it will show. For some people, it shows in their expression. A lot of people say, I can't hide how I feel. So imagine, even if I'm saying the right words, if I'm feeling sarcastic, it's going to show on my face. So it's important to actually control how you feel about the situation. So it may be a bit of a challenge, I think, to do that. But if you try to change your mindset, that goes a long way. And in terms of how do you do it in a time that's limited, like any other skill, with practice, you'll get the hang of it and you'll be able to do it, with a snap of your fingers, basically. So yeah, it's practice, 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 and the right mindset.
Yes, I do agree with you, Dr. Budi. We need to practice now. All right. Another question. We have a few questions. Please bear with us. From Prof. Callum Derward, do you agree that a series of encounters is going to be better than a one-off?
I do agree to that, because with a series of encounters, then you get to build rapport, and of course you get to actually when you build rapport, the response you get might also improve from your patient. And also with a series of encounter, it actually allows you to actually it's not categorize, but you can actually break up something which is very heavy and very long into shorter sequences. So it will be easier for the patient to actually see where you're coming from and see what they need to do next. Because otherwise, if it's going to be just one-off, then the impact might be less. If it's one very long session, it can just get lost in translation also. So having a few series of sessions might be better. But as I mentioned earlier, in terms of evidence on the dosage of the sessions, we don't actually have evidence base for it yet in terms of dentistry. So more studies would be welcomed so that we can know exactly what works best in the dental setting for that.
Okay. Thank you, Dr. Budi. Yeah, I do agree that, for us to achieve effectiveness of giving, for example, oral hygiene instructions, oral health education, we need that repetitive measure. You need to repeat our practice so that the patient can really adhere to whatever we advise on.
And also to encourage motivation, isn't it?
Yes. Okay. Another question from Dr. Horn, read with you. Do you think MI will be effective in a situation where participant is more than one participant? For example, if we try to convince a group of parents in an outreach area to improve their child's oral hygiene?
I think you can still use MI in a group setting. However, whether it will be more effective, I can't really say. But I think based on the principles of MI, where it's about really finding out where the patients are coming from, in a group setting, I think there'll be quite a limitation. First of all, the interaction, you will not be able to focus on all the patients at the same time. There will be some who will feel a bit left behind, and then there might be others who will be less comfortable to open up in a group situation. So even though you can still practice the technique of MI to a certain extent, but in terms of effectiveness, I think you will experience some reduction of effectiveness as compared to when it's on a one-on-one basis. Yeah.
Okay. Okay, just maybe we take another one or two questions. So from Dr. Aiman Nadia, I think the key challenge to get motivational interviewing that is actually effective is the level of competence of the clinicians to translate their training in MI into practice. There is huge potential in this method, especially when applied to patients from disadvantaged groups. Do you believe that this is something we should push for in primary care setting, delivered by our government GPs, who are the ones seeing the most patients from this disadvantaged population? I could be wrong, but most of the papers I came across that proved effectiveness of the brief MI were trials done in a dental specialist setting, which is kind of the ideal situation and not really reflective of a primary care setting.
Yeah, I do think I do believe that there's a lot of value in MI, and but I do agree that it can be a challenge to actually conduct MI, but I think we need to start somewhere, and as in other endeavors, for example, tobacco cessation, I think previously it's probably only done by public health specialists, but we know that patients who see GPs are also smokers, and the treatment done by the GPs will still be affected by the fact that they're smoking. So now, at least in Malaysia, we advocate for all the dentists to actually do brief intervention, at least in terms of smoking cessation. So I think similarly, this is something we should also do for MI. We should not limit it only to ideal situations, but rather we should find a way to actually bring MI to work in less ideal situations. Maybe there will be some compromises somewhere, but it's still possible to make that contact count, isn't it? That's the whole concept of the talk, making every contact count. So yeah, definitely, I think it's something we should definitely explore the use of MI even at primary care.
Yeah, I do agree that we have to use the time that we have efficiently so that we can, put all the correct words and give the correct advice, or, try to do this MI in a short period of time. This relates to the final question, Dr. Budi. So from Dr. Farid Nordin, just want to ask, from your observation practicing MI, how long does it take on average for a patient to show some behavior change? Thanks a lot, doctor.
Okay, all right. This is a tricky question, and there's no one right answer because it does differ. It differs to the patient. I've had some patients where I think at some point I just don't know what to say anymore to the patient because that's how challenging it is. And I think I did not make a dent despite, all the attempts I did for MI. And there are some patients where it doesn't take much and they are cooperative. And I think that even after one session, you can see that they've really gotten into the whole concept of that self-awareness is there, and that, you can see that the behavior change is starting. And when we talk about behavior change, we have to realize that any change is change, and we have to appreciate that. So I can't really say that it takes one visit or two visits because it does differ, and it also depends on how do you define change. Okay, I hope that can say something.
Okay. Thank you, Dr. Budi. Okay, there's just one more last question. I think this just went in. In your experience, how many percent does MI really works for our patients in the Malaysian context?
I don't really get what is asked.
I think this Dr. Ira Shazlin, maybe she is asking about how many percentage in the context that this MI really works in patients.
Oh, okay. Any successful
Story?
Okay. Well, I've had patients for tobacco cessation that have actually decided to want to quit. When we use MI, I generally do use it when I consult on tobacco cessation patients. I mean, it's difficult to say that it's, because it's a technique that we use. So I can't really say it's just purely because of the MI, because I do use it for in general when I look at patients. But if you were looking for let's say data on how it works, I do know that now in one of our in one of a new setup in Kedah, if I'm not mistaken, in the public health, dental public health clinics where they are employing MI in dentistry. I think that's something which is currently new and upcoming in Malaysia. So maybe we can get some data from them. And I have never really reviewed to say the percentage of my patients, but yes, I've had patients who we ask them to reflect back on their lives, on the reasons for change, what it means to their families, and they change for those reasons. And it's just actually, it's not so much what we do, but it's actually the patients themselves. The technique helps them come to that realization. So yeah, it has worked. For some patients, it doesn't work. I admit I've had my failures, funny situations, but it doesn't stop me from trying. And the good thing about MI is that even though it fails, the relationship with the patient is not affected, because I look at it as, okay, we're trying, but the patient doesn't resent me for it, because to begin with, the patient doesn't feel that I'm encroaching or I'm scolding them. So they're happy to see me again. It's just that maybe they're just not ready to change. So it's an ongoing work for us. So that's how it works, actually.
Okay, Dr. Budi. All right. So thank you again, Dr. Budi, for answering all the questions and for the very informative talk. So this concludes our webinar this evening. It is a great pleasure for me to moderate this session for the ICD session 15. And thank you all for attending. We hope you have enjoyed and gained something valuable tonight. Yes, now I would like to pass the session back to Professor Dato' Muhammad Ibrahim.
Thank you, Dr.
Thank you.
Thank you very much, Dr. Faiza, for moderating the sessions. And also thank you, Associate Professor Dr. Budi, for a very presentation of a different kind of nature that you usually have on clinical cases. I'm sure your topic tonight has made some of our colleagues realize the importance of speaking or communication to the patients. And again, on behalf of Section 15, I would like to thank both Dr. Faiza and Associate Professor Dr. Budi for moderating this session and so for sharing the knowledge with our participants tonight. Thank you again, and to hope that we meet again sometime in the future. Okay, to move on. Yes, as I said in the beginning of the session this is the first session in October, and in 2 weeks' time we will have a speaker. She is Dr. Simona Dianiskova. She's going to talk about treatment of Class 2 with Invisalign. So she's also the president of European Association of Orthodontists. So stay on, come join us in 2 weeks' time on 20th of October, same time, Malaysian time, 9:30, and hope that we'll have can see what Dr. Simona have to share with us on this topic. Again, thank you very much for joining us, and have a good rest, and stay tuned and join us again in 2 weeks' time. Thank you all, the committee members, and Dr. Amy and Dr. Datin Mayuna, who has helped me in arranging this program. Thank you and good night. Bye.
Thank you very much, Prof.
Okay.
Thank you. Good night. Thank you, everyone.
Prof. Thank you, everyone.
Thank you.